Good morning and welcome to week 5 of the University of Maryland School of Medicine 6th Annual Medical Symposium. My name is Oriomi Dowdu and I'll be your host for today's session. A special welcome to those of you that are joining us for the first time this morning, and to our participants from the Community College of Baltimore County and Maryland AHACS, thanks again for joining us this week. Today you will be hearing from Dr. Guralnik, but before I introduce Dr. Guralnik, I'll quickly go over a few instructions for the Q&A session. Dr. Guralnik will be answering your questions at the end of his presentation. If you're not using your video camera, you have the option of inserting questions in the chat box while the presentation is in session. Or if you prefer to ask your questions audibly, please raise your hand and you will be unmuted. If you've called in this morning from your phone, you can raise your hand by dialing *9. From your computer, click Participants on the Zoom menu bar, and a white Participants box should appear. From there, click the Raise Hand command at the bottom. If you're using the Zoom app on a tablet or phone, click Participants, choose More, and then choose Raise Hand. Now it is my great pleasure to introduce Dr. Jack Guralnik. Dr. Guralnik is a professor of epidemiology and public health at the University of Maryland School of Medicine. Prior to arriving to the University of Maryland, Dr. Guralnik spent 25 years doing epidemiological research at the National Institute on Aging, and was chief of the Intramural Laboratory of Epidemiology, Demography, and Biometry. Dr. Guralnik received his medical degree from Jefferson's Medical College and MPH and PhD degrees from the University of California, Berkeley. Dr. Guralnik's research on aging has been published in over 800 journal articles and book chapters, and he has taught and lectured extensively in the U.S. and abroad. Here to present Healthy Aging, Improving Mobility in Older Adults, Dr. Guralnik.
Hello, I lost you for a moment. Did you introduce me? I can't hear you.
Yes, you did. Yes, I did. I can hear you. Can you hear me, Dr. Guralnik?
Oriomi, can you hear me now?
Yes, I can hear you.
Okay. So is it? Are you finished? Is it my turn to start?
Yes. You can go ahead and show your slides. Yes.
Okay. Thank you for that nice introduction. I didn't get to hear all of it. I hope everyone can hear me. It's a pleasure to be with you today. I was hoping when I was invited that I would be with you in real life in Owings Mills, but that unfortunately has not come to be. But it's nice to be able to share at least through this mechanism. So I'll be talking today about maintaining the role of maintaining mobility in older people, particularly focusing on the role of physical activity. I'll also be talking about a condition that many of you have probably not heard of, but something that really we all have, and that's something called sarcopenia, which is loss of muscle mass and loss of strength. It starts at an early age. Some people have it more severely than others, to the point where it really affects their ability to function. So let me get into the slides here. Okay, there are a number of domains of functioning that we should consider when we're trying to understand health status in older people. You see these domains listed here, and during this pandemic, we hear a lot of talk about how we need to keep exercising, keep our physical functioning up, but also the importance of the other domains of functioning: cognitive functioning, keeping your mind sharp, psychological functioning, sensory functioning, social functioning. We're doing social distancing now, but we also realize the importance of having active social interactions, maintaining social support to really help support us during this difficult time. So in some ways, the stress of the coronavirus pandemic brings out the importance of all these various domains of functioning, not just for older people, but really for people of all ages. So in the area of disability, we think about several different domains, and we're talking here about physical disability. There is also disability related to these other domains of functioning. These are very simple classifications. We have the most basic, which is self-care, something called ADLs, or activities of daily living. These are your basic tasks that you need to care for yourself. Things like dressing and bathing and eating. We also, in older populations, in our epidemiologic studies and in clinical practice, in addition to assessing ADLs, we often assess IADLs, which are called instrumental activities of daily living. And these are other activities necessary to remain independent in the community. Things like shopping for food, preparing meals, paying bills, that sort of thing. And then finally, a more general kind of functioning, which is mobility or ambulation, both at home and in the community, known as mobility disability, when people are having problems in this domain. So there's a wide range of mobility in the older population. Here we see a couple that seems to have very excellent mobility, good balance. They're moving along and enjoying their walk. In this next slide, we move further over on the spectrum. This couple is doing pretty well. They're out there walking, giving each other support as they walk. Probably have slowed down somewhat from their earlier years, but they're still walking, perhaps having some difficulty with their walking. And then we move to the extreme end, and this is a really awful kind of way of thinking about older people. I found this slide actually in London, walking around the city there, and it stereotypes older people in just an awful way. But it does remind us that when people think about older people having problems, they often think about the mobility aspects of aging, the need for support from another person, from assistive devices, and that this is an important aspect of how older people have problems as they age. So mobility can be defined in a very simple way as the ability to move through one's environment without assistance. And efficient and reliable locomotion is a fundamental feature of human functioning, but indeed functioning across virtually all animal species. Now here we see some national data which shows the prevalence of difficulty walking a quarter mile. That's not a very long distance. It's, if you think of a track around a football field, it's one time around. So it's a distance that you would like to be able to walk to remain mobile in the community. And you can see that these rates are pretty high, rates of people having difficulty. They go up with increasing age, as you would expect. For each specific age group, we see that women do have a little bit more difficulty than men. Their percentages are higher. And by the time women and men get to be 85 and older, 70 or 80% of them have difficulty walking a quarter mile. So it's a highly prevalent condition. There's been a fair amount of work looking at the consequences of impaired mobility. People with impaired mobility have their impairments for many, many different reasons. And there's been a lot of study on how people develop impaired mobility, and then studies that I'll show you here on the consequences of impaired mobility. This comes from a national study using Medicare data, a survey called the Medicare Current Beneficiary Survey. And it simply divided people into those with no difficulty walking a quarter mile, some difficulty, but able to do it, and then unable to walk a quarter mile. And it shows a number of different outcomes. So in those who did not have IADL disability at the beginning, you see that as they were followed up over time, that there was an increasing rate developing instrumental activity of daily living disability. It went from 11% in those with no difficulty to 29% in those with difficulty to 47% of those who were unable to walk a quarter mile. We see slightly lower rates for ADL disability. If you remember, this is a disability in self-care items, a less common but more severe level of disability. So it goes from 4 to 14 to 23% of those who have problems walking a quarter mile develop ADL disability over the next year. The healthcare costs vary greatly from $9,500 on up to $13,000. And this is data from about 15 years ago. So these numbers would be bigger now. And then hospitalizations over 1 year, very big differences. So that those with no mobility difficulty, 25% of them would be hospitalized over 1 year. And that goes on up to 47%, almost half of people who are unable to walk a quarter mile would have a hospitalization over 1 year. This indicates that it's not the walking difficulty itself that ends up putting you in the hospital, but it's that walking difficulty represents the effects of multiple chronic conditions, people who are very sedentary and therefore lose their ability to walk, and often people whose conditions are more severe. So I'll talk a little bit about predictors of impaired mobility. There's been a fair amount of work on this. There's a study done in Italy that the National Institute on Aging sponsored called the Chianti study. And it looked at what we think of as the physiologic subsystems of mobility and focused on 6 important domains. And this was meant to emphasize the fact that the things that influence mobility are really multifactorial. So we often think of the muscles and the bones and joints as really the mechanical parts of mobility that we absolutely have to have, but other physiologic systems play an important role also. So for instance, the central nervous system is sending out coordinated signals to the body to be able to walk normally. The peripheral nervous system carries those signals. We have to be producing energy and delivering it. You need oxygen to your muscles for them to work well. So your cardiovascular system has to be working well. And then the sensory system in terms of sending input into the central nervous system to coordinate walking. So it turns out to be fairly complicated in order to understand just from a population level and also from an individual level what is affecting the ability to walk normally as people age. And there are a lot of ways of assessing walking. You can do just a simple usual pace walk. You can have people walk as fast as they can. And we also do provocative tests where we have people step over obstacles, where we ask them to answer questions at the same time they're walking. Walk on a narrow base, have a limited vision, that is, reduce the amount of light in a room, retrieving an object while they're walking, and then walking further distance or walking carrying a weight. So there are a number of different ways of assessing walking, and some of them are stressing people to a degree as they're walking, not just simple walking. So an important role that I'm going to talk quite a bit about today in mobility problems is the issue of loss of muscle. And we have a name for this, it's sarcopenia. It hasn't been around all that long, about 25 years. And it's defined as the age-related loss of skeletal muscle. Now, large longitudinal studies that have followed people over time have shown that people do start losing muscle not when they're very old, but when they're fairly young, even in their 30s. Muscle mass starts to decline slowly, then accelerates with aging. Sarcopenia comes from two Greek roots, sarx, which means flesh, and penia, which means poverty. You may have heard the term osteopenia, which is reduction in bone. Sarcopenia is reduction in muscle. And it can be very dramatic. Sometimes seeing a picture, you can remember these things much better than simply looking at a table of data. And so if you look at the far right of the screen, you see a healthy woman aged 33 years. And this is a CT scan at the mid-thigh level. And it's basically the white part in the middle is the femur, the big bone in your leg. And then all the gray around it is muscle. So that the leg is packed with muscle in this healthy 33-year-old. Now, all of these CTs are in healthy women, but of different ages. So then if you go to the bottom of the slide, age 55 years, you see quite a large reduction in the amount of muscle. And the darker area around it is fat tissue. And then finally, at 80 years, this is a healthy 80-year-old, but a tremendous reduction in the amount of muscle compared to the young woman here. So this happens to everyone. And people to different degrees. This picture was on one of the important gerontology journals to impress people that you can be 63 and still really muscled up and looking great. And so this was very impressive. This guy is a weightlifter. But interestingly, they went back years later and photographed him again. And here you see the picture. He still looks unbelievable for a 79-year-old guy, but compared to age 63, even though he was keeping up the same routines, he did lose a fair amount of muscle over that period of time. So even in the best of circumstances, there are physiologic changes in the body that lead to loss of muscle and loss of strength. What's interesting about this loss is that it happens differently for mass, which is how much physical muscle there is, and strength. And it's much greater loss for strength than it is for actual muscle mass. So this is data from a famous study being done in Baltimore called the Baltimore Longitudinal Study of Aging. It's done by the National Institute on Aging. It's been going on since the late 50s. And it really was, the study was developed to try to understand not so much diseases in aging, but the normal aging process in healthy people. And it shows decades of life, and it shows over that 10-year period, the percentage change in both strength, measured as knee strength, and in leg muscle mass. And for all ages, once you get beyond age 45, you see that the amount of loss of strength is substantially greater than the percentage loss in actual muscle mass. And this demonstrates that strength, which is really what we need in order to function, is not just affected by the muscle. It's muscle mass, how much muscle there is an important aspect of strength. But there are other issues such as the innervation of the muscles, the coordination of the contraction of muscles that play a role in strength. So we need to know about muscle mass, but we need to know about even more if we're going to understand strength changes with aging. We did an interesting analysis of data from a study that was originally started by the National Heart, Lung, and Blood Institute to study Japanese American men living in Hawaii. And it was originally done to try to understand why rates of heart disease in Japanese Americans living in the US, mainly California and Washington State, while they were substantially higher than heart disease rates for Japanese men living in Japan. And so they studied a place right smack in the middle of those two areas. They studied the Japanese Americans living in Hawaii and found, in fact, that they had intermediate rates, and this difference in race was probably related to dietary changes and acculturation and a variety of other issues. But the National Institute on Aging picked up this study after these men had been followed quite a while, and they had a grip strength measured when they were middle-aged. And we looked at those grip strength measures, and this is a test where you simply grab a device and squeeze as hard as you can. And see how strong people's strength is. And then we were able to follow these men up 25 years later. And they were initially very healthy. So there was a range of grip strengths that was not related to people being ill when they were middle-aged, but just a normal distribution. And what was found was very interesting. This shows the percentage, and this study was done in men only, unfortunately, but it shows the percentage who developed very slow walking speed. 0.4 meters per second is a very slow gait speed. It would be quite noticeable to see somebody walking at that speed. It's clear that they were having real difficulty walking. And so we looked at that according to tertiles, according to thirds of grip strength. So those in the highest third of grip strength, the bar at the top, had lower rates than those in the middle third, and those in the lowest third of grip strength had the highest rates of developing very slow walking speed. So this was not a self-report measure. This was an objective measure of gait speed. We also had people stand up from a chair and saw the proportion who were unable to do that. And you see the same kind of graded relationship to grip strength. So those who started out with the lowest strength had much higher rates of loss of ability to rise up from a chair 25 years later, after they had their strength initially analyzed. We also looked at this for a number of self-reported issues. Here is doing heavy housework, and you see that same graded relationship. Walking a half mile, walking up 10 steps, dressing, and using the toilet. So there are different rates for each of these self-reported measures, but in all cases, the grip strength in midlife was predicting difficulty doing these tasks in old age. And so this told us a lot about the long-term effects of lower strength. And probably, while the lower grip strength was not affecting people at the time it was measured in midlife, those with the lower strengths were closer to a threshold that once they got below actually caused them problems in the kind of activities we see here. So it's where you start, and then it's how you maintain your function over time that are related. Another thing that has an important impact on muscle is bed rest. And we know that as people get older, the rate of hospitalization goes up, and especially when people are quite ill and end up in an intensive care unit where they're immobilized for many days, sometimes weeks. It's been demonstrated that this has a really negative effect on their ability to function. This study was published in JAMA a number of years ago, and it is really very sobering. They took completely healthy people, not sick people, and they put them to bed for 10 days, and they looked at their muscle. And these folks lost over 2 pounds of muscle in the legs, over 6% decline in their leg muscle. When you think of a 2-pound steak, that's a lot of meat, a lot of muscle to be losing from your legs. And it translated into more than a 15% drop in lower extremity strength just from being immobilized for 10 days. We know that when people are actually sick, especially if they have an infection, an inflammatory response, certainly in people who have COVID-19, who are quite ill, the loss of muscle mass and strength is going to be even more pronounced than in these healthy people who were put to bed. So there's a big impact of bed rest on muscle loss. There's an organization that is involved in sarcopenia. I just wanted to mention, it's called the AIM Coalition. AIM stands for Aging in Motion. And they do have a website, which is not on here, but it's simply aginginmotion.org if you wanted to read more about sarcopenia. It's a diverse group of patient, caregiver, health, and aging organizations working together to press for greater levels of research and innovation around sarcopenia and age-related functional decline. So while sarcopenia is very common, it's not something that the general public knows much about, and it's not something that physicians think about very much. Geriatricians are starting to become aware of sarcopenia and its impact, but it has not really penetrated the general medical establishment that much. So this organization is trying to raise awareness of sarcopenia, its impact in the community, raising awareness of potential for behavioral or pharmacologic interventions to improve physical functioning and quality of life. And then also to work to try to develop outcome measures for functional decline that will show us how we're doing with our treatments of sarcopenia. I want to talk a little bit now about objective performance measures of physical functioning. It's an area that I've been quite involved with. And these are assessment instruments in which an individual is asked to perform a specific task and is evaluated in an objective, standardized way. These predetermined criteria, which may include counting of repetitions or timing of the activity as appropriate. Now, I mentioned different approaches to understanding disability, and the most traditional one is simply asking people or their proxy about how well they're doing in terms of self-care activities, activities to remain independent in the community. And people generally are pretty good at answering these questions, but sometimes people think they can do more than they really can do. Sometimes people are simply not confronting the problems that they're having. With these objective performance measures of functioning, you can actually do a standardized test the same way in all patients and really understand a little better just how well someone is functioning than by simply asking them these questions. So I want to talk about how this has been done. Now, I looked at the old medical literature to see if there was any tradition of assessing physical functioning in populations and in patients. And if you go through medical textbooks in the 19th and 18th century, when docs were really good at really understanding their patients, all they had really was observation. There really are no examples of using standardized physical assessments for functioning. I did find one historical example that's very interesting. Some of you may recognize what this room is. Since we're not all together, I can't ask you all to raise your hands if you recognize it. But this is the Great Hall in Ellis Island, the hall that people had to pass through in order to enter the US when they were immigrants. And in fact, in this setting, an objective measure of physical performance was used for health screening. And you see here a stairwell that people had to climb to get up to the Great Hall. And at the top of this stairwell, there was always a public health physician who observed people's performance as they climbed these stairs. And based on their ability to climb the stairs, a certain percentage of people were screened and looked at much more carefully to see if they had serious medical problems. But other than this example, there really aren't a lot of examples of using objective tests until recently to identify physical problems. I want to talk about a battery of tests that I developed with my colleagues at the National Institute on Aging some time ago, and which has come to be used quite a bit throughout the world as a simple standardized way of assessing lower extremity functioning. This is called the Short Physical Performance Battery, or SPPB, and it's got three different components to it. One is standing balance, and we have people stand first with their feet side by side. If they can hold that for 10 seconds, they go to a semi-tandem position, and if they are successful at holding that, then we see if they can hold a tandem stand, as you see here, for 10 seconds. We have them do a timed 4-meter walk, and this is at usual pace, and even you don't have to do it at a fast pace. People self-select a gait speed that really does seem to reflect a lot of their pathology and physiology. And then the hardest part of this test is we ask people to stand up and sit down from a chair 5 times as quickly as possible. Seems like a very simple test, but what we learned over time is that it's very powerful in predicting outcomes. And so I'll just show examples of someone doing this test. We first demonstrate each of the positions. This is the examiner demonstrating the semi-tandem stand. And then the woman doing it, we've worked up ways of spotting people so that the test is very safe. If she should lose her balance, he is right there to catch her and support her and get her back to the chair. This is the gait speed test. Again, he's walking behind her so as not to pace her, to let her find her own pace, but close enough that if she should run into problems while she's walking, he's there to assist her. And then finally, the chair rise test. This is done with the hands across the chest and with a standard chair. And first we see if someone can get up once, and if they're able to get up once, then we ask them to do it as quickly as they can 5 times. And we looked at a variety of outcomes related to this test. This was the most surprising and interesting outcome, and it was published in the New England Journal of Medicine in 1995. We looked at disability status 4 years after the test was done. And you see here the percentage who develop ADL disability. Now, these were people, the test itself is scored from 0 to 12, with 0 being the lowest performance and 12 the best. In this case, we only see scores ranging from 4 to 12 because we're starting with a non-disabled population. So none of them had scores of 3 or less in the non-disabled population. And you see a gradient of ADL disability going down to quite low levels in those with scores of 11 or 12. We also looked at mobility disability. And again, you see that same kind of gradient. And then this is the proportion who remain non-disabled. Everyone was non-disabled at the time their SPPB test was first done. And this demonstrates that even in people who are not complaining of any disability, none of these people at the time their SPPB test was done had complaints of ADL or mobility disability, but they had functional changes as measured by these objective measures that predicted the onset of disability over time. And these results have been replicated in many other populations. And it is quite interesting that these are almost subclinical changes in functioning that can be picked up if you do a standardized test, but are not picked up simply asking people about their levels of difficulty. So there are a variety of factors that affect functioning and mobility. In study after study, it was seen that one of the most consistent risk factors for developing physical disability, especially lower extremity related disability, was sedentary lifestyle. That those people who did not move around much, who didn't exercise, had substantially higher risk of becoming disabled. This was seen in a variety of different studies throughout the world, and seemed to be a very consistent finding. The question there was that even these were observational studies. The question remained, if you actually initiate an exercise program in people who are already, say, 65 or 70 years or older, can that prevent the onset of disability? It may be that if you have lifelong sedentary lifestyle, that it's too late to come in with an exercise program in old age to reduce the onset of disability. Or it could be that people are not exercising because they're already sick, and that lack of exercise is a marker of illness. And that's the reason that people are doing worse over time, because it's a marker of already being sick. And so there were a number of questions, not about whether in observational studies physical activity was predicting disability, but that doesn't prove causation. You need to do a clinical trial if you want to really get at the issue of causation, or in this case, prevention of an outcome. And so at the National Institute on Aging, a number of studies were developed. This is the largest study that was developed, probably the largest exercise intervention ever done in older populations. It's called the LIFE Study, Lifestyle Interventions and Independence for Elders, a randomized clinical trial of exercise to prevent mobility disability in non-disabled persons with functional limitations. So you see that at the end of this, functional limitations. This was identified through the SPPB test that we had already shown to be predictive of poor outcomes. And we were able to, using the SPPB, identify people at higher risk, those people with scores of 9 or below, we knew had higher risk than those with 10, 11, and 12. And while an exercise intervention for people with the high SPPB scores would be a perfectly legitimate study to do, we wanted to really focus on people who had higher vulnerability, higher rates of disability, and therefore focused on people with SPPB scores below 10. This study was first done as a pilot study that was successful, and then was finally funded to be a large multi-center study. So there were 8 field centers across the US. You can see them here, starting from the left with Stanford, Pennington, at Louisiana State University, University of Florida, Wake Forest, Northwestern University, University of Pittsburgh, Yale, and Tufts in Boston. So a wide variety of institutions across the country. The coordinating center was at the University of Florida. The National Institute on Aging oversaw this study and funded it. Data management was done at Wake Forest University. And this study was conducted from early 2010 to the end of 2013, over about a 4-year period. And as I say, it was a large study, actually brought 1,635 persons into the program. The physical activity intervention was a center-based program in a group setting. So people came in twice a week to a group setting. This was not necessarily a medical center. It was often a setting such as a Y or a community center. We wanted the study to have real application for public use after the study was done. So we didn't use any it didn't require equipment like you'd find in a gym. Could be done in people's homes. And in fact, they did 2 days a week in a group setting, and then the rest of the week they exercised on their own at home. So the intervention included aerobic exercise, mainly walking, strength training with a focus on strength in the lower extremities. And one piece of equipment we did provide people were ankle weights that they would put on to do their strength training. We had a balance component in this intervention, flexibility and stretching. And then there was also behavioral counseling, focused mainly on trying to get people to figure out ways of doing the exercise program the days they were at home, and also to try to support long-term compliance. As we all know, it's easy to start an exercise program. What's hard is keeping it going over a long period of time. We were quite successful in that in this program. So these just show some pictures of people in the program in different settings at Wake Forest, and then at Florida. They have a lovely exercise setting. You see here in Stanford, the weather's nice a lot of the time, so they had people walking outdoors. It shows people getting their blood pressure checked and then taking a break during the walk. And this shows the use of the ankle weights to improve strength in the legs. So the primary outcome in this study was what we called major mobility disability, defined as the inability to walk 400 meters at usual pace. This was tested on a 20-meter course where they did 10 laps, 40 meters per lap. And they had to do this within 15 minutes without sitting down. They had to do it without the help of a person or a walker. They could use a cane. They could stop for up to a minute to rest if they wanted. So it was a practical test of ability to walk this distance of 400 meters, which I mentioned at the beginning. It's about a quarter mile, and it's felt to be a distance that is really necessary for community ambulation, to get from the parking lot of a big store into the store, to walk around one's neighborhood. This is the minimal amount that people have to do to remain independent in those kinds of settings. So it's a practical outcome, and as opposed to asking people about their problems walking, this was actually observed. We had people walk, and they had to be able to do this walk in order to enter the study. And the study was really not a treatment study, but a prevention study. We were trying to prevent people from losing the ability to walk 400 meters. So this shows the results of this study among older adults at risk of disability, a structured moderate intensity physical activity program compared with the health education program, which was the control group, reduced major mobility disability by 18%. And then we also looked at persistent mobility disability. This is where people at 2 exams in a row were unable to do that walk. A certain percentage of people would be unable to do the walk, and then when they came back 3 months later, they were able to do it. They recovered. We saw, a fair amount of illness in this group. They were aged 65 to 89. So we had some, quite elderly people in the cohort. And we expected there to be a fair amount of concurrent illness. About 40% of our participants were hospitalized for one thing or another during the study, but often were able to come back and take up the exercise program again. And so the idea of persistent mobility disability, which was where they became disabled and then couldn't recover from it, was important. And here we saw an even bigger impact of the intervention, so that there was a 28% reduction in persistent mobility disability. And this was probably because people in the program, in the exercise arm of the trial, who became mobility disabled, were more likely to recover as related to being in the exercise program. So it had that benefit of not only reducing the onset of mobility disability, but also improved the possibility of recovery in those people who did become mobility disabled. So the conclusion from this landmark study is that although highly prevalent and increasing in size, the older, more vulnerable population has been understudied and typically is not included in large randomized trials. And life demonstrated mobility benefit of a physical activity program and provides a strong rationale for both the healthcare providers and community health systems to promote physical activity for vulnerable ambulatory older persons. This is a strong message from this study and has had an influence. Another thing that we learned from this study in a much more general way is that older people can participate in clinical trials and can do very well participating in clinical trials. They have high compliance rates. They want to follow the protocols of the study. They're often excluded from drug trials, especially by drug companies who want to keep their trials simpler, not have people who have other problems, not have people who may be hospitalized for some other issue unrelated to the disease being treated. And we are often in a situation where drugs have been shown to be beneficial in a younger population, but then the majority of use of these drugs is in people much older, and they have never been in clinical trials in that age group for this drug. Often the excuse is given that you just can't do clinical trials in people in their late 70s and 80s. And we showed here that this fairly complicated intervention that required a lot of participation was quite feasible in this population. So in terms of walking, one of the things that has been emphasized is the importance of physical activity at a certain level. But we've done some research that has shown that any activity is good. So we looked at a study called the Women's Health and Aging Study, which is another study done by investigators at Johns Hopkins, funded by the National Institute on Aging, in which we looked at older women who had moderate to severe disability. And we looked at those women who did at least a little bit of walking. And here we're talking about 6 blocks a week or more, really a very modest amount, and showed that the walkers had much less decline in their SPPB scores. And so we had different models, which basically just included different variables that we were adjusting for, but are quite similar. And it shows that this is the mean change in SPPB score in terms of points, and that those who were completely sedentary, didn't walk at all, had almost a 1-point decline in their SPPB score, whereas those who did even a little bit of walking had much less decline. And so we gave this paper an unusual title to get people to pay attention to it. You can see that at the top. We called it "Just Get Out the Door: The Importance of Walking Outside the Home for Maintaining Mobility." And there needs to be more research in this area, but for people who can't or won't do full exercise programs, even a small amount of exercise probably is beneficial and can reduce functional decline. So I'll end with this slide, and this kind of shows the importance of doing more research in older populations. It shows the proportion of men and women who survive to age 90 and older. And if you go back, this is a historical slide, and this is when you take 50-year-olds in 1900, only about 3% of the men and women would go on and live to age 90 or older, a very small percentage. 50 years later, by 1950, things had improved somewhat, not tremendously, but 5% of men and nearly 10% of women who were age 50 could be expected to go on and live to 90 or older. In the end of the 20th century, mortality rates dropped a lot in older men and women. And here we see data for 2013. These numbers have continued to rise a little bit since then, but about 20% of men and over 30% of women who reach age 50 can expect to live to 90 or older. So what this means is that a very high proportion of our current 50-year-olds are going to live to 90 or older. And that's a lot of very old people. The question is, what kind of shape are they going to be in? Are they going to be fully functional and independent, or will they be disabled and in need of long-term care? That has a major impacts for the healthcare system, for the need for long-term care, and really for the financial burden on not only the healthcare system, but the whole economy and the burden on families that are caring for these people who are living into their 90s. And I'll end by showing you this book on physical activity and exercise that's put out by the National Institute on Aging. There you see the website that you can go to order these books. They're free. They often have CDs available that you can use to actually do the program. The books are very well done. They were put together with the advice of a lot of people who are experts in physical activity for older people. So I recommend this program, or really any program that can get you up out of your chairs and out the door to be physically active. So I will stop there, and I'll stop my screen sharing and go back and be able to take questions at this point.
Excellent. Thank you so much, Dr. Guralnik, for that presentation. We'll be taking questions now. You can raise your hand on the app. Dr. Guralnik, we have one question in the chat box from Diane Terry. She says, are there medications for sarcopenia like there are for osteopenia and osteoporosis?
Yeah, that's a really good question. There are not now. And there are a number of different drug companies working in this area. There have been a few breakthroughs in terms of understanding the physiology of muscle loss, and they've attempted to develop medications that can have an impact. It's a bit of a controversial area. You know, as I said, everyone is losing muscle and losing strength. So we clearly are not going to be treating everyone after age 65 for muscle loss. But there are circumstances where a medication could really be beneficial. For instance, I showed you the data for people who are hospitalized. So say someone coming out of an intensive care unit, it often takes months for these people to rehabilitate to the point that they can walk normally and they can be mobile in the community. If we had a medication that prevented or reduced the amount of muscle loss, it could be very beneficial. Hip fractures are unfortunately very common in the older population. Most of you have probably known someone who had a fractured hip, and people do very poorly in general after hip fractures. They have a lot of mobility problems. They struggle a lot with the ability to get around. And if we could, and we know that during the rehab time, people are not able to move all that much and lose a lot of muscle. So the drug companies have been particularly interested in hip fracture patients, where the treatment would not be a long-term kind of treatment. It would be more of a short course of treatment that could boost muscle or support muscle to prevent loss during this time after hip fracture, and could potentially really help a lot of people get back to full functioning after their fracture. So we hope that there could be some viable drugs, but they're still in the pipeline, and there's nothing that's out yet.
Thank you. I see a hand, Mr. Burney. I'm going to unmute your hand, unmute your you now to talk. 1 second. Go ahead.
Thank you for a wonderful presentation, and that supports a lot of observations that I saw over 48 years of clinical practice. I used to evaluate patients by asking them how long it took them to make their bed in the morning. They could do it within 4 or 5 minutes. You were generally normal. But as I've gotten older, I've gotten interested more about sarcopenia. And so I find that sarcopenia leads to poor posture, which leads to shift of your center of gravity, which leads to imbalance, which leads to more sarcopenia. So as the sarcomeres atrophy, can the remaining sarcomeres hypertrophy to replace loss of function and strength? For example, in those people who have recovered from polio with hypertrophy of the affected muscles.
Yeah, these are really excellent observations. I like the bed making test. Maybe we should initiate that as a standardized test. It could tell us a lot. There is evidence that you can improve muscle strength in people who have lost quite a bit of strength. And in the case of polio, that often happens at younger ages. And then, as you know, some people later on do start to suffer again when their muscles kind of poop out. But in older people, it has been demonstrated that strength, even in very weak people, that you can increase strength. Now, do you actually increase the size of the muscle fibers? I think that's somewhat debatable. What they find is that a lot of the increase in strength has nothing to do with increase in muscle mass. That when you look at the change in strength in an exercise program, it happens well before there's any actual observable change in muscle mass. There may be kind of change in muscle mass down the line, but there's a lot that happens in terms of the neuromuscular junction, how the nerve is stimulating the muscle, the firing and the coordination of the muscle contraction that can be a result of an exercise intervention before you even see an increase in muscle mass. And you can have beneficial effects from exercise even when you don't get very much increase in muscle mass. But you definitely can see increasing muscle mass even in people that are not starting with a whole lot of muscle. It just may not be something that should be the goal. It should really be, as we've studied sarcopenia more, we've realized it's really the strength that counts more than the muscle mass itself.
You know, as just in a personal aside, in order to maintain my quads, I climb the steps 2 at a time. Of course, having a banister nearby for safety.
Yeah.
I find that, you know, after I lay off from that for about 6 or 7 weeks, I have to retrain myself to do it again.
Yeah, you lose it quickly, don't you? Unfortunately. That's a good exercise. I think that stair climbing, you know, people shouldn't start with 2 stairs at a time. They should start with one.
No.
And then work up to 2 at a time. But that's
Thank you.
it's good training.
Well, thank you very much for your response.
Thanks for your comments. Yeah.
Thank you, Bernie. Do we have any more questions? You can raise your hand in your camera, or you could add it in the chat box.
I see one in the chat box, a private one, saying,
Okay.
what are the causes of sarcopenia? And that's an excellent question. And I'm not sure we fully understand the causes. We see sarcopenia in a number of different chronic diseases. Certainly, people with cancer lose muscle mass, they lose strength. We see it in heart failure, we see it in diabetes, we see it in chronic kidney disease. So it's a consequence of a number of different chronic diseases. We also see it in people with no diseases at all, a sarcopenia related to aging, but an accelerated loss of muscle. It at times can be hormonal. In men, the level of testosterone they have supports their muscle mass, and so loss of testosterone can have some impact on muscle. And being too sedentary certainly also causes an accelerated loss of muscle. So there are a number of different pathways, and I think we're still learning, about how this whole process takes place. But as I showed you from those cross-cutting CT scans of thigh, that even in healthy people, there is a tremendous loss of muscle once you get into your 80s and 90s. And I wish we knew exactly why and that we could intervene on it. Other questions?
Any additional questions? Okay, I see Mr. Ladden. I'm going to unmute you 1 second. Go ahead.
Besides exercise, besides walking, what is the best exercise for older adults if you're not doing walking?
Well, strength training can have many benefits, and that can be, done at a gym, but our gyms are closed right now. But there are ways to do strength training without using equipment. Variety of ways, from doing push-ups for upper extremities to using small hand weights. There's strength training that can be done with expandable bands that you pull on. The books that I showed you have a number of strength training exercises. So I would say it's nice to do a combination of walking or some other aerobic like swimming or bicycling along with lower extremity strength training. And even simply doing what we do in our SPPB test, which is standing up from a chair 5 times. That's a form of strength training also. It's a test we do, but it's also a form of strength training that I encourage people to do if there's no other way to do strength training in a more formal way. But it can be done fairly easily.
Thank you.
Dr. Guralnik, we have a question from Mr. Robert Wolf. He asks, is yoga effective to deal with sarcopenia?
Another really good question. I'm not sure I know the answer to that. You need to do some resistance training to deal with sarcopenia, so that weight training, and there's some yoga exercises that are similar to weight training. The general yoga exercises are terrific for stretching and keeping the joints mobile. I'm not aware that anyone has actually done a clinical trial of yoga to see if specifically if it has an impact on sarcopenia. People with sarcopenia who are having functional problems would absolutely benefit from doing yoga. But I can't say for sure that it would change their measures of sarcopenia.
Great.
Anybody else out there have any other observations about yoga and muscle strength?
Go ahead, Mr. Burney.
Not so much about yoga, but about balance. Is there any benefit to standing on these rotary platforms that move back and forth, where you have to maintain your posture and upright position? The closest I could think about something like that would be to stand on the deck of a small vessel that's rocking gently in the water, where you have to shift your posture back and forth to maintain your balance.
Yeah, that sounds like great balance training. Balance is one aspect of functioning that can be readily trained. I mean, even simply standing on one foot several times a day can help with balance training. But there are more high tech methods using different devices, like you say, to do balance training. But if people are having balance problems, I strongly encourage them to do balance training, because it works. It really, you can clearly see improvement without, fairly short order, and highly beneficial to prevent falls.
Well, that standing on one foot used to be part of the field sobriety test for the state troopers. And they had to eliminate it because the older people couldn't do it.
Yeah. Yeah, it's not a fair test, is it, for sobriety?
Right. I mean, if you're 14, it's great. But if you're 83, it's not so good.
I do have a private message about that pilot studies exist in older adults and the effect of yoga and balance. And that's a good point. That there've been, yoga clearly has benefits for improved balance. And while we don't know, I don't believe anybody's done work with yoga and sarcopenia. If balance is an issue that you're dealing with, yoga can be very beneficial.
Friend who lived to be 106, and she insisted on suspending herself almost daily from her door frame for as long as her fingers would allow her to hold on. When she passed away, her spine, she was almost ramrod straight in the pictures that she would pose for.
That's impressive.
Okay, do we have any additional questions?
And it looks like Jennifer Kirk has sent a paper to people that can be downloaded. I believe it's on yoga and balance.
Yes. Thank you, Jennifer, for sending that. Okay. If we don't have any additional questions, I guess this concludes session 5. Dr. Guralnik, thank you so much for your time this morning and sharing this with our audience this morning. We really appreciate your time. So for next week, we will be hearing from Dr. Rhea Kerbick on palliative care and pain management. The same time, 10 o'clock, next Tuesday on May 26th. Thank you all so much for being with us this morning. Thank you.
Thank you. Bye-bye.